It is an honor to have the opportunity to introduce our paper published in AJR through YouTube. The paper I will present today is titled Coronary Artery Calcification on Low-Dose Lung Cancer Screening CT in South Korea. Visual and Artificial Intelligence-Based Assessment and Association with Cardiovascular Events. There is a high probability of revealing in-center findings beyond pulmonary nodules in low-dose CT lung cancer screening, as LDCT lung cancer screening is performed in older individuals and heavy smokers. In a study of NLST, clinically significant in-center findings were observed in 33.8% of patients. Emphysema and coronary artery calcifications are the two most common in-center findings, which account 43% and 12.1% respectively. CAC is a recognized predictor of major adverse cardiovascular events. American College of Radiology recommends routine reporting of the presence and severity of CAC on LDCT lung cancer screening. In a case of positive CAC, patients should be evaluated with the risk of atherosclerotic cardiovascular disease. In non-ECG-gated CT, CAC can largely be divided into visual analysis and quantitative analysis. Visual analysis has the disadvantage of being subjective, and quantitative analysis has issues related to the accuracy of the software used. Furthermore, both methods have issues regarding how well they correlate with ECG-gated CT. Considering these factors, a modified length-based method was introduced in 2023, and AI-based software applications such as AView CAC and single calcium scoring have also been launched. However, image analysis method on CAC findings remains incompletely understood, and a universally accepted method has yet to be established. The aim of this study was to assess the prevalence and severity of CAC using visual analysis and AI-based methods, and to characterize the association of CAC with MACEs in patients undergoing LDCT as part of South Korea's National Lung Cancer Screening Program. LDCT lung cancer screening is performed in individuals with age 55 to 74 and a history of more than 30 pack years of smoking, whether a current smoker or a former smoker in whom smoking cessation occurred within the past 15 years. Search of packs for baseline LDCT scans conducted at either of two centers as part of Korea's National Lung Cancer Screening Program from April 2017 to May 2023. Patients with a history of coronary artery disease, cerebrovascular accident, heart surgery, or a peripheral atherosclerotic ischemia were excluded. Final study sample included 1,002 patients. Follow-up data was available in 625 patients. In a Kaplan-Meier analysis, 589 patients with at least 90 days of follow-up were assessed. Axial CT image shows CAC in a 73-year-old male patient. CAC was assessed as severe by consensus visual analysis. CAC score was 376.0, consistent with moderate CAC by AI software application 1, AView CAC. CAC score was 407.2, consistent with severe CAC by AI software application to single calcium scoring. An occupational medicine physician reviewed the EMR through November 11, 2023 to identify occurrences of MACE after the LDCT examination. The 2 tertiary medical centers included in this study are designated as regional cardio-cerebrovascular disease centers. MACE was defined as any coronary artery disease event, including acute myocardial infarction, percutaneous coronary intervention, or coronary artery bypass graft, ischemic stroke, acute peripheral atherosclerotic ischemia, or all-cause death. There is a strong male predominance in this study population. This strong sex imbalance is a recognized characteristic among participants in the Korean National Lung Cancer Screening Program, as reported by a prior study from the K. Lucas, which reported 97% of men and 3% of women. Positive screen results were observed in 10.7% of patients. There was no statistical significant association between positive CAC and positive screen result. The prevalence of CAC ranged from 53.4% to 60.1%, with CAC severity classified as mild, moderate, or severe in 28% to 39.9%, 10.3% to 14.3%, and 6.2% to 15.1% of patients respectively, depending on the method of CAC assessment. Between consensus visual analysis and AI software 1 as well as AI software 2, there was some moderate or substantial agreement, and a higher degree of agreement was observed with simplification of classification. In the 2-tiered classification, there was an almost perfect agreement between consensus visual analysis and AI software 2, which seems to be because a thoracic radiologist performed manual corrections in the case of AI software 2. A MACE was recorded during follow-up in 5.6% of patients. Coronary artery disease events were recorded in 4%. Ischemic stroke was recorded in 0.8%. Acute peripheral atherosclerotic ischemia was recorded in 0.16%, and all-cause death was recorded in 0.64%. There was a significant association between the CAC severity and the occurrence of MACE. MACE showed a significant increase with increasing CAC severity for 4-tiered, 3-tiered, and 2-tiered classifications. For consensus visual analysis, AI software 1 and AI software 2. These figures also indicate the specific pairwise comparisons with significant differences for the occurrence of MACE in the 4-tiered and 3-tiered classifications. The 3 methods yielded over similar patterns regarding CAC prevalence and severity, although variations among methods were observed. Increasing CAC as determined by any of the 3 methods showed a significant association with the instance of future MACE. South Korea was the first Asian nation to initiate an active national lung cancer screening program using LDCT. So these findings provide reference data for healthcare practitioners from other nations engaged in developing and overseeing national lung cancer screening programs. highlighting the importance of routine CAC evaluation. Thank you.